सर क्वेश्चन आंसर तो इधर आते हैं सर।
ठीक है उसके
इसमें
यूट्यूब में
इसमें यहाँ पे सर चैट कर
ठीक है
ये सर आपके सर
ठीक है स्टार्ट करते हैं। स्किप करके जाना पड़ेगा। So good morning students. I hope some of you have joined through YouTube link. I understand that because of the COVID situation we have to take this platform. So before starting the topic, I would request you to post your questions whatever you have on the YouTube chat platform, and then we can take up the questions if there are any. I hope I'm audible and the screen is visible to all of you. Fine, so I've cross-checked, it is visible, and so I'm starting the topic. This is basically lower urinary tract obstruction, which means anatomically it is bladder outlet obstruction. As students, we know that the lower urinary tract system consists of the bladder, the urethra, whereas the upper urinary tract is basically the kidney and the ureters, the kidneys and the ureters. So if we what do you understand by lower urinary tract obstruction? What are the conditions? We'll be dealing with certain causes, etiologies, the common ones that we see, and how we deal with them, how to evaluate them. You must understand that some of these can present in an emergency setting also, for example with acute retention of urine. So it is of utmost importance that we understand the common causes of bladder outlet obstruction and how to deal with them. So as we know, the picture suggests, as you can see here, it's the bladder which takes the brunt in case of bladder outlet obstruction. The bladder responds first by by trying to get rid of the obstruction by increasing the detrusor pressures, and in terms of how prolonged the obstruction is, whether it is an acute and short-lived one, the outcome would be different, and if it's a chronic one which goes on, the obstruction continues to linger, the outcome would be different, maybe with effects on the upper tracts. By upper tracts we mean the kidneys, the ureters, and also depending on whether it is partial or complete, the outcome would be different. So what are the conditions? If somebody asks us about the etiology, it could be broadly classified into congenital causes, infective or inflammatory causes, as we classify every disease, also trauma, as here you can see in this slide. These are called the straddle injuries. Here of course there is another group where we have stones. The stones can get lodged in the bladder. This stone could be from the kidney which has fallen down, rolled down, or it could primarily start in the bladder itself. So depending on that, we have different management strategies. And of course malignancies, I would say there are examples. Prostatic malignancy in adults, I would say, is a very common condition. Even neoplasia of the benign type, that is benign prostatic hyperplasia, is also quite common in adults, of course. So but here I would try to focus on the conditions that we see in children because of the background from which I come, since this will form a template. The pathology and the response of our body to obstruction would be more or less same in the other conditions, of course depending on how short-lived or long the underlying etiology is. So depending on that, we will take up posterior urethral valve as a one condition, and we'll discuss of course about the others in brief. It is important to understand that since it is congenital, the posterior urethral valves have certain manifestations which are not seen with trauma or with those with stone or those arising because of malignancy. So here you have to understand that because the kidneys are yet developing and this lesion is congenital, in fact it is fetal. not only congenital, it has started in the embryonic period. So it has certain effects. The posterior urethral valve would have certain effects on the developing kidney. So the developing kidneys which are yet to be matured enough are highly susceptible to injury from bladder outlet obstruction, and we'll see how do they manifest. One more important thing is, the earlier the obstruction is, that means it means that earlier the obstruction, the more deranged the parameters would be in terms of the kidney damage. So for that matter, if a posterior urethral valve will have a more deleterious effect on the kidney compared to those with stone, the outcome would be better in stone, because it hardly has produced any effect on the growing kidneys. So you take care of the stone, the outcome would be straightforward. It won't have any long-term effect per se. However, in posterior urethral valve, since it has some effect on the developing kidney, even after the urethral valve is taken care of, it may have produced irreversible damage on the growing kidneys. So with that in mind, let's see how does this congenital form of bladder outlet obstruction manifest, and what is the epidemiology. It's not very common and even not rare. We see it quite commonly in males. So posterior urethral valve is a disease of the male gender, and it occurs in about 5,000 to 8,000 male births, 1 in every 5,000. And this is a very not an uncommon cause of antenatally detected or prenatally detected cause of hydronephrosis. So you may have realized by now that those who come for antenatal checkups, we advise them timely ultrasound screening for any fetal anomalies. So amongst those, some of them are life threatening, so where they would be advised for termination of pregnancy. But for those conditions, for those congenital anomalies which may not be life threatening but could affect certain organ systems but would not merit termination of pregnancy, one of them, a very commonly detected condition, is hydronephrosis, and it could have a myriad of causes, but posterior urethral valve is one of them. So here you can see it's the schematic representation. The valve is like a one-way valve, which is supposed to be a one-way valve. Sorry for that. So the one-way means, if you see the disposition of the valves, the urine which is coming from the kidneys, ureters and downstream would get affected, obstructed. So one-way passage of urine is affected but the reverse would not be. Of course, the physiological direction is from kidneys and out, so in effect it means it has produced obstruction, and therefore you can appreciate the prostatic urethra, which is quite dilated here. This is the verumontanum, and just distal to the veru we see these leaflets, fleshy leaflets, valves, which should not have been there, these marked by these arrows. So that produces some upstream changes, and here you can see, as compared to the other bladder here of a different pathology, of course, see the bladder wall is not that thick here, but here the bladder wall is quite thick, almost you could say 10 times of normal, and there are some mucosal irregularities here. These are the outpouchings because of the increased pressure that it has to handle and it has to push through, and the urine, the pressure in this is again transmitted up through these ureters. They become dilated, they become tortuous, and the kidneys are now hydronephrotic, and these are not normal. So it has the valves, although are here, the effect it produces is also on the lower urinary tract system, that is the bladder, as well as on the upper urinary tract system. So that is what it is all about, and it is diagnosed in about 1,000 ultrasound screening if it is done. It's quite common in our setup, and once it is managed, it's not a one-time treatment, because of the fact that I have already told it has affected the growing kidneys. It has had some effect on these kidneys. They will keep coming to us with problems related to chronic renal failure. So although obstruction, if treated timely, it would have in effect a good outcome, it should have, but may not be in all cases. It would have some effect on these kidneys, which merits them to be seen at least annually, lifelong, because quite a fraction of them, about 1/3 of them, would land up with transplantation, kidney transplantation later in life. So that was about the males. So what about in females? In females, similar condition but not valve per se. You would see here some blobs. These are the outpouchings of mucosa. From which part? From the from the VUJ, that is the ureteric, where the ureter enters into the bladder. It should have had holes here. These are the ureteric orifices, but instead the openings are stenotic, the mucosa bulges, so there is a pre-stenotic dilatation, and these are called the ureterocele. And if they become quite big, some of them can actually prolapse across the bladder neck. Here you can see this is the bladder neck. One of them is prolapsing, the other is not. This is simple ureterocele. So these, although these are lesions of the vesico-ureteric junction, they can produce bladder outlet obstruction because of their anatomy if it is crossing the bladder neck. So if somebody asks you what are the common causes of bladder outlet obstruction congenital, in males it is posterior urethral valve, and in females it would be ureterocele, bilateral or unilateral. To understand more, we must also understand how the kidney develops. I'm sure you are well versed with the anatomy, how the the cloaca develops around the 4th, 5th week of gestation, and this is the common cloaca is, as we know, is a common channel into which the alimentary tract and the developing urinary system opens up. It's a common channel to start with, and this should be, this is the future urogenital region, the external orifice. Now the anal orifice is not yet formed, but as it develops around 7th week or so, you can see around 5th week, the cloaca is divided into an anterior chamber and posterior chamber, as we see in the future or the postnatal anatomy. How it happens? By one urorectal septum. So if we again go back to that diagram, here you can see this urorectal septum developing cranially, migrating caudally and dividing this cloaca into an anterior chamber. Here it is complete. So here is the urogenital system, urogenital here, and this is the bowel or the anorectal canal. So this urorectal is very vital. It forms and divides this cloaca, now having separate streams. Of course, it is an urogenital, which means depending on the sex, what it ultimately will develop into, it can have the opening of the urethra. Here it is the phallus developing. It's the male fetus. The phallus would develop, the urethra would be surrounded by this phallus, or else it would develop into the clitoris, and this would be the vulva of the future female. What happens from the kidney ureteric bladder perspective? You can see here this blue thing. What is this blue thing? Is the mesonephric duct, and something here, the yellow one also developing. This is the ureteric bud. So this is happening in the urogenital area. Okay, so I'm sure you would be aware of the kidney system or the renal or the urinary system, how it develops in a 3-tier mechanism. The mesonephric ducts of the promesonephros, the mesonephros, and the metanephros. As the gestational age develops, continues, you can see the primitive ones degenerating. The mesonephric ducts, these are para-midline structures, which are the primitive urinary system. They gradually disappear. However, the duct or the Wolffian duct, this is the Wolffian duct, the future Wolffian duct or the mesonephric duct. So they develop, and they would regress, and they go down, they settle down, migrate down, and at a point just proximal to this cloaca bilaterally there would be buds seen, which are nothing but the ureteric buds, the final or the future ureteric bud with these ill-defined zone around them. They are called the metanephric blastema. Metanephros, which are the metanephric blastema, the future kidneys. And as we know, they have to migrate up. The kidneys migrate up bilaterally. The ureteric bud develop into the ureter, the collecting system. They branch, they sub-branch, they branch multiple times to form the collecting system. So this is the ureteric bud, and the metanephric blastema surrounding it forms the kidney, the cortex. So that is fine. What happens in the around the cloaca, and this is the posterior view of that. The cloaca has now become, the bladder, the future, because the urorectal septum has divided the bowel backwards. It has separated and it has gone backwards. But what it remains, what we can see from behind is this is the mesonephric duct and the ureteric bud developing bilaterally, symmetrically, and then gradually it becomes part of the bladder. Both of them, they are taken up as the embryo develops, and then you can have separate. To start with, they were common branched pattern, but if you can imagine that this part is being it is being absorbed by the developing bladder, they will now have separate openings, and that is how it is. This is the ureter, and this is the vas deferens, which is nothing but the part of this mesonephric duct, which is also called as the Wolffian duct. So this is the vas deferens opening. This is the verumontanum, seminal vesicle, and this part, which is the purple one, the part of this common terminal part of the mesonephric duct, forms the future trigo. So I'm sure you have read this. You could go again and see this picture. Little confusing, but I am sure you will understand because it's a step-by-step procedure. And that is how this is the bladder future, this is the trigone, the ureter, and the vas deferens in case of males. Why it is important to understand is that the posterior urethral valve, which I was talking about, happens somewhere here. The pathology, there is improper absorption of this, improper development of this mechanism. This mechanism gets altered, thereby leading to improper absorption of tissues with residual fleshy structures left behind, leading to formation of these valves, which are just behind the union of these two the vas deferens, which forms the seminal vesicle, and the verumontanum, or the ejaculatory duct. If you remember, the structure which forms by union of the bilateral vas deferens opens into seminal vesicles. It's not shown here, but final single opening is called the ejaculatory duct on a mound, which is called the verumontanum. So if that is so, why it is important for us to know all this? Because this is the pathophysiology of bladder outlet obstruction in fetus. In fetus, what happens if there is obstruction? What would happen? The intravesical pressures would rise, because the bladder is not used to store urine in high pressure. If somebody asks what is high here, it would be something more than 40 millimeters mercury of mercury. If something centimeters of water, 40 centimeters of water, then it is called a high intravesical storage pressure. That would cause the detrusor muscle, which is nothing but the smooth muscle of the bladder, to generate. It initially tries to compensate the obstruction, and it tries to get rid of the obstruction by generating excessive force against this outlet resistance, which could be temporary, which could be permanent, as in a valve to start with. With this, throughout antenatal period, the urine is evacuated and forms the amniotic fluid. As we know, 90% of the amniotic fluid is nothing but urine, and it comes from the kidneys, goes through the ureter. The bladder tries to empty it by generating excessive force, and what happens is the bladder becomes massively hypertrophic, and the detrusor muscles, they become hypertrophy, and thereby leading to formation of saculations, trabeculations, and diverticula in the bladder. the anti-reflux, if we I'm sure you know that the ureters are meant to allow flow of urine in one direction from the kidneys, the ureters, and downstream across the UV junction, but that mechanism fails, that is the anti-reflux mechanism fails, and they become incompetent, and now the urine goes up, causes ureteric dilatation, the ureters become tortuous, and the kidneys become hydronephrotic. So we end up having kidneys which look like this, which are enlarged, hydronephrotic. The ureters are massively dilated. Here you can appreciate that, and the bladder wall is quite thick, unlike a normal bladder detrusor wall, which would not be that thick. So this is the response basically. Not going into the details, but if you can appreciate, this is the normal bladder, and the end stage of a chronic obstruction leads to formation of a bladder wall with thickened muscle, and the collagen distribution is also abnormal, leading to a fibrotic bladder. So it becomes initially hypercontractile, but later on it is not pliable, it's a rigid, like a coconut. Coconut, if you have seen, most of you know about it, it's a thick rind like structure, which even if there is some space inside and urine collects somehow, it would be unable to contract fully to evacuate the urine. Ultimately it becomes a rigid container. So I think I'm not discussing this. I've covered the main important part about this slide is that 90% of the amniotic fluid is derived from the kidneys. So what happens if there is a bladder outlet obstruction? There will be oligohydramnios, and that leads to the oligohydramnios leads to abnormalities which predominantly affect the lung development, because it is now understood that the amniotic fluid acts as a factor for the development of the lung. You know, it mechanically as well, and it contains trophic factors. So the amniotic fluid goes up, it is swallowed and aspirated. The lung is now not functioning, of course, because the oxygenation is being taken care of by the placenta, but here it is developing, and this lung development is now restricted because of oligohydramnios. So it will have poor acinar growth, decreased surfactant production, and this would have effect on the postnatal life. I will discuss that. But the developing fetus will have some abnormal appearance, which is called as the portus facies. You can see the flat facies with an interpalpable distance which is enlarged. It will have some abnormalities in the foot as well, and of course the developing lung, the underlying lung would not be normal. The child will certainly develop respiratory distress in the postnatal period, because the lungs are not mature enough as it should have been because of poor lung development, and most of them require ventilatory support after they are born, and then it can lead to demise. Just to elaborate on that a little bit more, so P is for, you can just remember it, pulmonary hypoplasia, oligohydramnios, twisted skin, or it looks like skin of an old man, twisted face, that is the portus facies, abnormal facies, extremity defects, club foot, because there is oligohydramnios, restricted space for this fetus to grow, and therefore it will have club foot. Renal agenesis, of course, is the prime cause here. Bilateral renal agenesis, no urine, and it can also happen in bladder outlet obstruction even if there is the kidneys which are not absent. So renal agenesis is not required for Porter's syndrome, but if there is renal agenesis, it is certainly possible to have a Porter's syndrome. But even if the kidneys are well developed, but if the bladder is outlet, the obstruction, if there is obstruction of the bladder and there is bladder outlet obstruction, that fetus will also have Porter's syndrome. So this is the mechanism. I have already elaborated on how it happens, the various mechanism of development of a Porter's syndrome. So now coming back to the topic proper, what are the causes? I have already discussed the most important one of them, that is in males the posterior urethral valves. Rarely we can have anterior urethral valves as well. We can have urethral polyps. There could be ureterocele, and this ureterocele is more common in females. So in this table you can see it is in the top of the chart, and other abnormalities we have discussed them. So we can have trauma, strictures, tumors, of course. Okay, so what are the clinical presentation? What would we expect? So once the child is born, we can appreciate, we should have a normal stream of urine. The stream of urine shouldn't be like a dribbling of a tap. So the first thing that we see, that we hear from the parents, they come to us saying that the child is not passing urine in a good stream. So the stream is affected in most of them, having a bladder outlet obstruction, be it congenital or be it because of a stone. So that they can have severe pain. Those having stones will have pain in the lower abdomen, especially when the child starts micturating. The child can have strangury, can have hematuria. So these are the problems that can happen in a little older child. Those having some stones, those having stricture because of a trauma, as a sequelae to trauma with a urethral injury. But here in a neonate, the prime concern is about the urinary stream. We don't expect the child to come with pain, because we would not, the child would not be able to vocalize. So here we have to look carefully at the abdomen. If the bladder is palpable, we have to check for that, because it's a chronically obstructed, dilated, thick-walled bladder. And if we in a sleeping child, sleeping neonate, if we palpate, we can very well appreciate the enlarged, fibrotic, hard bladder in the midline, in the hypogastric area. Of course, some of them can be asymptomatic, the milder ones. So posterior urethral valve is a spectrum. It's not always a preset symptoms that they develop. Some of them will have very high grade of symptoms, and they are called they would in fact demise. They will have fetal demise. Some of them, they manage to be born, and once they are born, they can have a very severe post-natal course with respiratory distress requiring ventilatory support, and then demise. This is the Potter syndrome. And the better ones are the ones which have milder symptoms. They will somehow not manifest with Potter syndrome, but will have a poor stream. So these are the pre-selected milder varieties which end up not demising, and these are the ones which we will see, and we will try to salvage them from developing or going into a chronic kidney disease. So of course, urinary retention, overflow incontinence is a condition where the bladder is itself not evacuating. There is obstruction, of course. The primary problem is obstruction, but the presentation is unlike obstruction. He will have incontinence, continuous dribbling. So why it happens? Because of the obstruction, there is accumulation of fluid or urine in the bladder, and at beyond the capacity, it's like you have to imagine a bucket having a small hole in the bottom of the bucket. What happens when we fill water in it? Because of a small hole, it will continue to dribble. It's not completely obstructed, but it will continue to dribble, and it will be continuous till the bladder empties, till the bucket empties. So in the same thing happening here, as we have by now understood that the bladder ends up behaving like a rigid, non-flexible, non-pliable container with the urethra, which is of course obstructed but not 100%, because it's just a mechanical one-way valve. Still there is a scope of urine to dribble across it, and if the pressures are so high, it will present as incontinence rather than complete obstruction. So these are various ways by which they can present to us. And of course the end stage and UTI, they will have urinary tract infection because of stasis. Urine is supposed to come out, it is not supposed to stay in the bladder for a prolonged period of time, But in this scenario of posterior urethral valve, they will have stasis, and the stasis invites urinary tract infection. That could be just a simple UTI, or it could cause ascending infection and the kidneys can become pyonephrotic, and then it is called urosepsis. So UTI, which could be just simple UTI, can also manifest as urosepsis. And the last stage would be renal failure of various grades. We classify them into CKD 1, 2, 3, 4, 5. We would read that in pediatrics and medicine more about it. But ultimately some of them would land up with renal failure requiring transplant. I'll just check the time to. Okay. So in a neonate, I have already mentioned this, that they can have a palpable suprapubic mass of the bladder basically, and they can have neonatal sepsis because of UTI per se. So UTI presenting as neonatal sepsis, and respiratory distress as a part of Potter syndrome because of the underlying lung which is not mature enough. And then of course we have also discussed about the symptoms that we expect: history of dribbling of urine with a poor stream and failure to thrive. These patients will have continued problems, urosepsis, UTI, lingering UTI, so they will not grow properly, the weight gain would be poor, and so it is also one of the causes of failure to thrive. If you would this is a short note, in pediatrics, failure to thrive, there are so many causes. One of them is bladder outlet obstruction with recurrent urinary tract infections. So this I have told, enuresis is basically the overflow incontinence. The child will have weight loss, vomitings and diarrhea. These are non-specific symptoms of urinary tract infection in infants and neonates. They are not directly linked to the kidney system, these symptoms, but if a child has UTI, they can present just with vomiting and diarrhea. So one has to rule out urinary tract infection in these patients. So the urinary pattern, if you chart the urinary flow against time, you get a graph which is called the uroflowmetry. It's a normal bell-shaped curve. So it rises, peaks, and then slows down. However, here because of the obstruction, it would be, it's a staccato pattern, interrupted pattern. So that is how a bladder outlet obstruction presents if you do a uroflowmetry. This is a bedside test basically. We can do it in our clinic, OPD clinic. We ask the child to micturate on a container which has sensors on it, and the graph is immediately plotted out in the computer using softwares, and the shape of the graph itself gives us an indication that the child here in this case is having or going through some problem in emptying his bladder. So these are objective measures to tell, since the parents may not be able to tell you exactly that the child's stream of urine is not good. Some of them would be able to say, some may not, but this is an objective way of deciding or categorizing the urinary stream into a normal pattern or having a staccato pattern, which again gives you an indication of what type of pathology you are dealing with. So what else we can do? We have to of course they can have the manifestations of chronic kidney disease itself. We know chronic kidney disease would have problems related to can have hypertension. The child may not grow as normally as others, a small short stature, can have pitting edema in the long term, ascites, and of course enlarged palpable kidneys could also be seen. The other features I'm not dealing with them. This is just for completion. I think it would be too much for you at this moment. So how to investigate them? Now we have background knowledge of the history. We have some conditions in mind. So if a child has UTI, if the child is having failure to thrive, having urosepsis, recurrent UTI detected by positive urine cultures, prior history, so we'll have to investigate. We'll have to shorten or shortlist and finalize our diagnosis. How would you do that? By investigating them. What are we trying to look into? We are trying to do some tests which will tell us where exactly or the site of the obstructing pathology and how severe it is, whether it is a partial one or it is a complete one. Of course, how bad the kidneys are, how extent of the urinary tract reaction means how the what's the status of the upper tracts. So is it already compromised or still good enough in a reversible stage? So we need to know that, because then we are in an urgent situation to get rid of that obstruction. But if it is completely already compromised, we have to think otherwise. So what is the status of the renal function? Split renal function means of the total glomerular filtration rate. We know the GFR of a healthy child would be something above 70 or 80 ml, per minute per 1.73 meter square body surface area. But how much of it is being contributed by each kidney? So is it 50%? What that means, both of them are equally functioning, or one of them is completely gone because of a pyonephrosis or because of agenesis. So that is called a split renal function and the total renal function. What is scarring? Scarring is nothing but the end effect of pyelonephritis, because if a child has UTI and it has caused pyonephrosis or pyelonephritis, those nephrons are lost and the kidney will have a scar on a nuclear scan as a cold spot. There are scans which give us the uptake of the kidneys, and if there are patches of fibrosis in the renal cortex, it will be shown up as a scar. So that is nothing but an indication of previous pyelonephritis leading on to scarification. Of course, if some kidney is badly scarred, we expect no function or a less split renal function in that kidney. So looking at those scars itself and looking for uniformity of the renal shape, we know how bad the kidneys are. And presence and degree of reflux and other associated anomalies. Reflux is the vesicuretary reflux here I am talking of. We'll discuss that in another slide. Okay, what are the other blood parameters or other investigations? So hemogram is very much important. If a child is in UTI, the platelets may be down. In case of sepsis, urosepsis, we have to keep a track of that. More importantly, the blood urea and creatinine levels, these are very important. And of course the ABG, because we expect metabolic acidosis if the kidneys are knocked off because of whatever reasons. If UTI, urosepsis and the child having acute renal failure, there would be metabolic acid base balance in the form of metabolic acidosis. Urea would be raised, creatinine would be raised. One thing I have missed out here is to also send urine culture. Urine culture would give us the underlying status of the urine, whether the child is having urinary tract infection or not. After that, the easiest imaging modality, which is cheaply and widely available, of course, is the ultrasound. So it gives us the status of the kidneys. Here it's almost a normal kidney, so it will give us the size, how big the kidneys are they hydronephrotic? Here you can see this is a normal kidney, here it is hydronephrotic, so dilated pelvic calyceal system. And bladder, I have not shown a picture of bladder, but here you can appreciate if ultrasound is done, the bladder wall, it's not bladder of course, when focused on the bladder it can show how thick the bladder wall is. So bladder and whether it is able to empty properly or not. So ultrasound should be performed with moderately filled urine bladder, and if the anomaly is found, we should repeat it by asking the child to evacuate and check whether he is able to evacuate it completely or not. So is there stasis inside? That is called the post void residual urine. So many things can be checked, and a quite good amount of information can be obtained by doing ultrasonography alone. So starting from the upper tracts, the bladder, and the function, limited information on the ability of the bladder to empty itself by knowing the post void residual urine. What else we do? This is a gold standard for detection. You can see here the urethra, this is the pendulous or the penile urethra, and this should have continued up in the same manner, but here it is hugely dilated. This is the posterior or the prostatic urethra, dilated because of valve here, which you can't see here because it's a very thin structure, but I'm sure you can appreciate a radiolucent, very thin radiolucent leaflet, I would say, that is causing the bladder not to evacuate properly because of this obstruction, and in the process the prostatic urethra has dilated, the bladder has developed, you can appreciate the diverticuli multiple. So this is how it looks like in an oblique micturating cystourethropography film. This is all you must learn, must remember for now. Nothing beyond that is expected of you. So just again showing how a normal MCU should have been. So this is the place. Instead of this urethra, you end up having this kind of a urethra with, of course, back pressure changes. Here a smooth outlined bladder, here an irregular bladder. This was the nuclear scan I was talking of. These are basically agents which are taken up by the DMSA is the dimercaptosuccinic acid. It is stacked with technetium, which is nuclear imaging modality. It is injected and the kidneys take up. So here you can see the reniform shape very nicely preserved. But if there are, so this is an example of same study but underlying renal scarring. So there are irregularities. These are the foci of previous pyelonephritic pyelonephritis, which has led to fibrosis probably, and that is how this scarred kidneys look like. A very irregular shaped kidney, unlike the smooth reniform shape of a normal kidney. So this gives us an idea about previous attacks of pyelonephritis. The other modality is invasive, is the urethrocystoscopy. So we go directly using a cystoscope and look for how the changes have occurred and try to document these are, and we could, the best part about this is that we could also intervene and they can be therapeutic as well. I'll show you a video regarding that. So right now I'm quite sure that you have ended up, you have narrowed your diagnosis, and after doing all the investigations you would have ended up getting the true diagnosis of this patient. So how do you manage them? Management is basically dependent on what your diagnosis is. For example, if it is a calculi, the calculi has to be taken out by whatever means you have, by operative or by other energy ESWL. We could have lasers, so they end up breaking the stones and the stone is evacuated. If it is a stricture, the stricture has to be repaired. If there is a neoplasm, the neoplasm or malignancy, that has to be removed. So I will show you what we do for posterior urethral valve, because the treatment is completely different from the rest of the conditions. Here we are dealing with I'm skipping these slides. These are, I think, not required at this stage. So okay, so treatment of posterior urethral valve is, of course, to stabilize the child first. If the child is sick, we need to stabilize. It's not very urgent in the sense that we need to stabilize the child first, resuscitate, and then give antibiotics if there is underlying infection, establish bladder drainage, because we know that valve is one way. Instilling a catheter and we expect the catheter to go smoothly into the bladder. The obstruction is on the reverse, the normal physiological pathway, but not in the retrograde manner. So a catheter can be instilled, and if it enters into the bladder, we leave it to drain so that the chronic obstruction is at least temporarily taken care of, and we do something to get rid of those valves. That is done by, again, endoscopy, cystoscopy. So we go there, we reach the spot and ablate or incise the valves at 3 positions. So I'll show you a video regarding that. And once those valves are hooked and cut, the valvular mechanism doesn't remain, and the obstruction is therefore taken care of. So let us show before that. These are the hooks. This is the cystoscope. It has a optical channel through which we see. This is the eyepiece. There would also be one working channel, and the working channel is being managed by these rings. So we put our fingers they can be brought together. So there is a forward and backward motion of these hooks. These hooks are attached here, so we can move them backwards and back and forth, and engage this hook onto those valves at various positions, 5 o'clock, 7 o'clock and 12 o'clock, and then get rid of them. Just incise them. We don't excise them, we incise them, and that process is called ablation. We could just cut them with a cold knife, or we can use electrocautery. When we use these, they are connected to a electrocautery machine, and the electrical energy or the radio frequency is used, the electrocautery is used, that cuts them in a bloodless field. So if we use electrocautery, the process becomes all the more bloodless. The vision is not obscured because of bleeding, if at all it occurs. Using these are cold knives, we don't have any energy here. We just use them to hook and cut and catheterize them for say 24 to 48 hours, and that takes care of the valve. So just a video regarding that, I'm sure it should work, or otherwise I'll show you the let's see if it works. Okay, so here we have positioned the child in a lithotomy position, and this is the knife I was talking of, the cold knife, sickle shaped. So here you are in the bladder, that's the bladder, and this is the bladder neck area, just at the outlet. But we know that the valve is little beyond this, so we come down. Little more proximally. This is just to show that this is the verumontanum. We have now reached the verumontanum. This is the sickle trying to engage, find out, locate the valves first. So we are trying to come more proximally. Whenever we try to find the valves, the verumontanum should be inside, so that gives us a reference as to where that's the ejaculatory duct, opening of the ejaculatory duct. So right here you can see, as we go more proximally, more distally, these are the folds. So you can hook them, you will have a better picture at this point. See, this is the valve, a fold, a wheel of tissue which can be hooked by our sickle. This has now engaged the tissue. This valve will now be incised, waiting for that to happen. So let's see whether our sickle is sharp enough. Yes, so it has incised it, as you can see here. We'll do it little more elaborately till we are sure that we have completely incised it. This was the 7 o'clock position. If you know this, if this is a clock, the valve has now been incised at 7 o'clock. Now we are going to the other side, that is 5 o'clock. So here again we see the fold, the hooks have been engaged, and see the incised valve, you can appreciate, I'm sure. Then we turn the sickle towards the roof, which will now enable us to, this is the ejaculatory duct, just rechecked our position, then going up towards the roof, hooked, and you can see it cutting it almost halfway through, and the final cut, sickle gone, and that's it. So this is how we ensure that the valves are taken care of. But just going to the presentation. Okay, so that ends the initial management. So what we have managed to do is we have taken care of the valve. However, the management would be lifelong for this child. We have to keep this child for follow up for quite a long time, even beyond puberty. because at generally at around puberty there is a increased, the muscle mass, the developing the already compromised kidneys may not be able to handle the urinary metabolic requirements, the metabolic waste of the body, and they deteriorate, end up having a chronic kidney disease. They may go downhill into CKD 5, and then they must be then uh, handled by our nephrology colleagues who work them up for transplant. And one third of these group, the posterior urethral valve, end up having or requiring a transplant later in life. So they also require other medications for chronic kidney disease. Some of them would have hypertension, for which antihypertensives are also required. So this is a long process which they have to go through, and of course once managed appropriately they do have a good quality of life, provided they are identified pretty early, maybe even antenatal period, and then taken care of at each stage. I'm sure you will have some comments. I'm sure, just let me check the comments if at all they are. So if there are none, yeah, so I can see the live chat. Is there a risk of recurrence? No. So okay, so it's not a recurrence. Good question you have asked, I would say. So recurrence in the form of true recurrence is zero. The chances of recurrence are virtually zero. However, what could happen is that in the initial management, initial cystoscopy, if the field is not good because of bleeding, because of whatever reason, because of a technical failure, if you are using a knife which is connected to the electrocautery and the electrocautery failed in the midway, so you end up taking care of the valves partially. So you can have a residual valve situation rather than a true recurrence. So this patient may require another setting of cystoscopic valve ablation. So we do have cases where they are referred to us from outside, in whom the valves are still present but not in the true sense recurrence, but they would require again an intervention. But these are called valve ablation or residual valve ablation. So thank you. In any case, if you have more doubts, you can reach me. This is my email address. It is duaanjan@gmail.com. Okay, so thank you. I am shutting it off